Schwartz. Everybody hear me?
Just a little louder, please.
Oh, sure. Thank you. My name is Schwartz, and I am a proud community member. I volunteer a lot. Part of my volunteering is my outreach. You'll see my iPad set up right here. And the reason why I do this is so that people in our community get to hear important issues about what's going on here in California, Berkeley, and in this purpose, Albany too. Become more involved and actually get them to do something about things that they may care about. And I've been doing it for a while now, so I probably have a lot, like more than 100 videos out there. I do various commissions, the Rent Board, Housing Advisory, City Council, you name it. I've done a lot. And mostly because these are issues that I'm interested in and that I am concerned with. And I'm learning a lot too. Secondly, I particularly came here today to ask you, the Commission, I know you can't respond right now, but about the issue of people with mental illness and the connection to homelessness. And I'm interested in this because I care about the homeless population in general, but those in particular with mental illness. And I want to know how we can try and resolve the issue and what people with various mental illnesses are faced with and why they become homeless to begin with, and why they cannot be housed, and what services we have and what services we don't have, and what resources we have, and why people are or are not able to obtain them. And also, I'm interested in a piece of legislation that has to deal with conservatorship for people who are homeless. I'm wondering what your thoughts are, if you've discussed this before, how that would help, how it wouldn't help. I just feel really awful thinking about people who are homeless on the streets who can't help themselves, where they're either, abused or post-traumatic or dealing with drug abuse, or it's just horrible to me, and it puts their life in jeopardy, and it doesn't make me feel good, and I want to be able to help, and I'm reaching out to the public, I'm reaching out to you to try and solve this great problem, especially here in Berkeley. Thank you.
We have a presentation tonight from Lifelong. Over there so I can see people better.
Yeah, that'd be great.
See everybody. Thank you. So I'll introduce myself in a moment when I get myself situated. I'll just pull a chair forward. I do this kind of informally, since it's a relatively small group and I'm kind of an informal person. Take some time to introduce myself and talk a little bit about Lifelong, and then find out what you're interested in hearing about, and be able to talk to you some about the different services that we are providing, both specific around behavioral health issues and mental health issues, as well as some of the special programs that we have where we embed mental health services and where we work collaboratively with the City of Berkeley and other Berkeley agencies. So my name is Brenda Goldstein. I've worked at Lifelong for 13 years. I'm the Psychosocial Services Director, and in that capacity, I do a variety of different things, including leading our effort to integrate behavioral health services into all of the different kinds of healthcare that we offer and social services that we offer, as well as looking at how we provide comprehensive services to patients who have complex needs and members of our community who have complex health, mental health, and psychosocial service needs. I did bring packets about Lifelong because I don't know how much all of you know about what Lifelong does, and I wanted to make sure that you had some context in which to understand the specific services that I'm going to talk about that relate to mental health services. Lifelong has an interesting history. How many of you would consider yourself very familiar with lifelong medical care? Una. Hopefully, Margaret and Shirley, okay. To some extent. Okay, well, it might be a little bit of, I may say some things that you know already, but hopefully it won't be too much that isn't new to you. Lifelong started, the very first clinic that is part of Lifelong is the Over 60 Health Center, which is over on Sacramento and Alcatraz. And that was actually started by the Gray Panthers as part of an effort to make sure that older folks who were low income had the services that they needed to stay healthy and be able to stay in their own community. And with an acknowledgement that the services that were required were not just medical services, but that people really needed to get social service support as well as mental health support. And so our very first clinic was focused on older folks who were vulnerable to developing disabilities and potentially not being able to live on their own or to live in community. And recognizing the fact that to be able to stay independent is a lot more than having your physical health care needs met, but that we wanted to be addressing the whole person. And since that clinic started about 45 years ago, Lifelong has grown considerably. As you can see in the packet, there are a lot of different services that we offer. We actually have 16 primary care clinic sites now, and we serve about 67,000 people a year, which is huge growth over the years. And we have clinics, we have 3 primary care clinics in Berkeley, our Over 60 Health Center, West Berkeley Family Practice, and our Ashby Health Center, and we also have an urgent care clinic in Berkeley, as well as providing services in permanent supportive housing for formerly homeless adults, and also we provide some services at Rosa Parks Elementary School. And we also have clinics in Richmond and Pinolles and Pablo Rodeo, and we have several clinics in Albany. So our scope is kind of along the East Bay corridor. But our home clinic and a lot of commitment has been geared towards making sure that we are able to meet the healthcare needs of low-income folks living in Berkeley. And our primary business is primary care. And a lot of people think about primary health care as being medical care. So when we go to our primary care doctor, we're going for, annual checkups or to get preventive care or to help get care for chronic health conditions like diabetes or asthma, or for urgent care needs if we develop, acute conditions and so on. But the approach that we've tried to take at Lifelong is that we think of primary care as being more than just physical health care, but really being whole person care. And to meet that approach, we have made sure that all of our primary care clinics have mental health services embedded in the primary care model. So if you were to go to our Ashby Health Center or to West Berkeley Family Practice or to the Over 60 Health Center, we have plenty of doctors and nurse practitioners who can take care of the medical needs, but we also have licensed clinical social workers and psychologists and psychiatrists, as well as substance use counselors to take care of behavioral health needs as well. And we don't hold ourselves out to be a specialty mental health clinic. So we're not interested in taking the place of Berkeley mental health in terms of being the place that people who have specialty mental health needs and are only interested in getting their mental health needs met. What we really want to do is take care of the whole person. And we generally provide mental health services to people who are also our medical patients. So typically, somebody will come to us, most often people will come to us because they do have a medical need or they want to get medical care. And part of what we offer them as being part of their primary care provider is to say, we also have mental health services on site. And if you're interested in getting those services, you should let us know. So once somebody is our primary care patient, they can self-refer to get counseling services. They can, their primary care provider can make a referral. Could be that the medical assistant who's talking to them about their diabetes or their asthma may notice that they have a need and say, hey, did you know that at Lifelong you can get mental health services? And they will help to make that connection then with one of the LCSWs or with a behavioral health community health worker who can help link them up with services. Because we take care of so many people, we are not able to provide super long-term therapy. So typically, people in a primary care clinic like ours will be able to get 8 to 12 visits of counseling. Some people may get longer counseling than that, but a lot of people will want and get shorter counseling. If they want longer term and counseling every single week, we may refer them outside because our capacity is limited within the primary care setting. So we let people know up front, this is what we have the capacity to provide, and we'll support you if you want to get care here. We'll also support you to get linked to services out in the community if that's your preference. We provide all sorts of different approaches to therapy. Almost all of our mental health providers are well trained in cognitive behavioral health approaches, in different approaches to serving people who have trauma. All of our work is focused on harm reduction. So with a belief that anybody in our practice has the capacity to make change. They may be at a different point in their life of making, what changes they want, whether it be their mental health, their physical health, or substance use issues. And we will support them to identify what changes they want to make and help them to make those changes. We don't turn anybody away if they're actively using drugs or alcohol. We don't insist that somebody use medications, although we are able to work with our internal psychiatrists as well as the primary care providers if a person is interested in getting prescribed medications for mental health conditions. Let me stop there and see if you have any questions or areas.
There's a couple of things. In terms of primary care, I'm wondering, first of all, do you have formal screening initiatives in place so that people are screened for mental health issues like depression, anxiety? And the other question with regard to harm reduction, the substance use disorder, do you use medication-assisted treatment?
Let me answer those in the order that you asked them. So we do, across all of our clinics, have an initiative to screen everybody for depression, universal screening for teenagers and older. We also have screening that's specific to women who are pregnant and postpartum. And we use evidence-based tools to do that, screening, and it happens routinely. And our electronic health record is set up to let us know when somebody is due for that screening. If somebody starts care with a behavioral health licensed provider, they will get screened for a variety of different things. So they will get screened for depression, anxiety, trauma, and substance use routinely. And then depending on what kind of symptoms they're having or behaviors, they may get screened for other types of things. Some of our clinics also have a very an interesting process that's a collaboration between counselors, LCSWs, and psychiatry, where we use the screening tools to really track improvement in symptoms so that we're able to see whether people are getting better through the treatment that they're getting, and to be able to take a look and say, well, they've been in therapy for 6 to 8 weeks. It doesn't seem, we reassess as we go along using the PHQ-9, which is a very well-established screening tool and assessment tool for depression, and trying to use a little bit of data along with the relationship that we have with a person to really hopefully keep people on track towards having some recovery and being able to get relief from symptoms, and working to see, should we be taking a different approach with counseling? Should we be offering medication to the person? What combination of things would potentially work for that person? One of the issues in primary care, particularly around medication management, is that, as you probably all know, psychiatry is in high demand, and psychiatrists tend to get booked way out into the future. One of the things that we're trying to do in the primary care setting, in collaboration between our primary care providers, the doctors and nurse practitioners, and the psychiatrists that we have, is to expand access to medication management by having the psychiatrists act as consultants to the primary care providers. So a psychiatrist can do an assessment and make recommendations around medication management, help a person start onto medication if that's what they're interested in, but then hand over management once the person is stable to the primary care provider, but always be available to be a consultant to that primary care provider, so that if they have questions about medication management, they have an expert in-house that they can talk to.
Are you speaking of psychotropic
Yes,
medication?
specifically around psychotropic medications. But there's also the interplay of what happens when somebody, for example, has medications for cardiovascular disease or for diabetes, and the interplay of those medications and their health conditions with their mental health treatment, and wanting to make sure that we're all on the same page. So because we approach our mental health service as a primary care service, the mental health providers and primary care providers all sit in the same offices. They talk to each other regularly. The medical record contains records for both mental health as well as medical care, and we educate our patients when they become our patients that that's what our practice is like, and that it's an integrated model where there's close communication among all of the different providers in the practice, and that we believe that that's a really good model for making sure that we're taking care of the whole person. So many psychotropic medications have an impact on cardiovascular disease in particular, and we know that people who have mental illness are particularly vulnerable to having cardiovascular conditions and having a hard time managing those. So we're particularly wanting to make sure that there's very clear communication and tracking of those health conditions for people who are getting psychotropic medications. I did want to answer your other question, unless this is related. Okay, let me answer the second question, and then Erlinda, I'm happy to answer your question as well. So yes, we do have medication-assisted treatment at all of the clinics in Berkeley. We have 7 or 8 of our clinics now in our primary care network that offer buprenorphine for opioid use. And buprenorphine, it's a medication that is used to help people who have an opioid use disorder to stop using opioids, and they get a prescription for buprenorphine, and it helps them to cut back or stop using opioids. And it's a much safer medication, and it's been proven through research to really assist people with recovery from opioid use, either heroin or opiates that have been prescribed for pain medication.
So what do you do with the condition if the person is using the opiates for, say, severe back pain or sciatica or all of it,
So that's
So
really
what do you do with the condition? How do
Sure.
you treat the condition?
So it's a good question, because pain management is an important part of primary care, and so one of the things that's happened because of the focus on opioid use and the opioid epidemic and people dying from opioid use is there's been a lot of evidence that opiates are, number one, first of all, they're very addictive. Number two, they actually don't work very well for pain management after a person has been on them for a long time. They actually are not the best approach to pain for many people, and their most useful approach for opiates is for very short-term acute pain, but not for chronic pain. So, but it's also very scary for people who have pain and have been using medications for a long time to think about getting off of medications, and because pain is so debilitating for folks. And so really approaching it from again, a whole person perspective around saying, look, we are worried about your opioid use, because opioid use is dangerous. People die from it. They have overdoses are not uncommon. And we want to make sure that we're prescribing safely for people. So we offer alternatives in terms of other medications. We have, we can offer referrals to our behavioral health clinicians who are able to work with people around mindfulness and other meditation and other approaches to being able to address pain management. We have some pain management groups. We have acupuncture at several of our clinics for pain management. So we're looking at alternative therapies. And I would say that I don't think we've come far enough, neither within our own clinic, but also within the field of really understanding how to help people manage their pain. Typically, we find that people, even when they say that they've had a lot of issues around pain, that when they are off the opiates and go on to a medication like either methadone or buprenorphine for management, they actually do better around their pain. And they're also more able to engage in other ways of managing their pain. So we don't take it lightly. It's not about, we've got to throw out your pain management, your pain medications, and we're not going to help you with anything else. We want to really help and walk the person through a whole process. And that process can take months to help somebody really get on track.
I guess when I asked about harm reduction.
Berlin, is this a whole bunch of us?
Two questions that are related. How are you funded? And two, do the patients have a copay or something?
Okay. So we're funded through a variety of different methods and sources of money. Our main source is through Medi-Cal billing, and upward of 75 to 80% of our patients are covered by Medi-Cal. And so we bill the state. Anybody who is on Medi-Cal does not have any kind of copay. We also, in Alameda County, for people who are uninsured because they're undocumented adults, so almost everybody except for undocumented adults, if they're very low income, has Medi-Cal coverage at this point, even undocumented children. Undocumented adults in Alameda County are able to get coverage through something called Health Pack. And we accept Health Pack as well. We're funded through Health Pack. So we get funded by Health Pack, and there are no copays for Health Pack. We also accept some private insurance, and we also take Medicare. For people who have no insurance coverage and are not very low income, there is a sliding fee scale. We are not allowed to turn anybody away. As a federally qualified health center, we're not allowed to turn anybody away because they can't pay.
Just a final follow-up. Is Health Pack a state program?
No, it's an Alameda County program to fill the gap so that everybody has access to funding. What's that?
Is it out of general fund?
It's out of general funds, yes. And we provide services in Contra Costa as well, and the coverage for undocumented people in Contra Costa County isn't even close to what Alameda County has done. They've really been one of the leaders in providing coverage for undocumented adults.
Thank you.
Yeah, you're welcome. Cheryl?
I just wanted to thank you for everything that you do.
I'm going to go.
Thank you.
And then
You're welcome.
I want to be in the queue.
Me too.
You're all in the queue. It's going to go like this, and then it's
Fine.
Yeah, and Bruno, you can, I'm here as long as you want me to be here.
Yeah,
So,
we
so you'll
have
keep me,
a lot to do.
right, so you'll keep me on track. I'm counting on you.
I will give you a 5 minute.
Okay.
Paul?
No questions.
Ma'am? I have, I want you to speak to the extent of your partnership with Berkeley Mental Health and how you coordinate those services and what the integration of the two organizations looks like.
Sure. So one of the things that I didn't mention is that although we are not a specialty mental health clinic, we actually take care of a lot of people who have serious mental illness. And so there are a lot of people in Berkeley who both get medical care from us and mental health services from the city of Berkeley, as well as people who get medical care from us and sometimes get care from the city of Berkeley, but sometimes get care from us for their mental health treatment. And there's kind of back and forth between us. We have a lot of communication that I would say mostly is by provider to provider. We aren't on the same electronic health record, so it's not possible for us to easily transfer information without making that happen on a case-by-case basis. And I would say an area for for development or improvement is to figure out how we can better identify when there is overlap between our clients across systems. We are in regular conversation with Steve and with others at the City of Berkeley around ways that we can collaborate more. We are specifically in conversation right now about ways that we can collaborate specifically for issues impacting homeless individuals and making sure that people who are homeless are getting access to both physical and mental health services, getting their whole healthcare needs met. In the past, we've had a primary care provider who actually has come a couple of times a month to Berkeley Mental Health to provide medical care on site to BMH clients. And we'd like to be able to do that again once the space issues are addressed and BMH is settled.
Yeah, I think actually we're planning to get it back, but we're working on the MOU right now.
Yeah, so, and my guess is that provider will probably come out of our Ashby Health Center, which is at the Ed Roberts campus, and close to BART and easy for people to get access to. And that kind of a collaboration, we do that with Alameda County and with some other community-based agencies. We find that works really, really well because there are people who come to Berkeley Mental Health who may have challenges coming into a primary care setting and making that work for them. And their health home really is the mental health setting. It's not the medical setting. And so by being able to put our medical provider in the mental health setting, it creates better access for people who may have other challenges in getting services.
So in terms of, I think I want to know this. You guys were around when homelessness was, at a certain stage, and right now is probably the biggest crisis we've seen.
Absolutely.
So what needs have you seen change amongst the homeless population in terms of healthcare and mental health care?
Just more people coming in who are homeless and who really can't get on top of their healthcare needs because of their homeless status. Certainly issues around aging and homelessness, cognitive decline, and issues related to homelessness, as well as cognitive decline for people who are in permanent supportive housing. So we provide case management and mental health and medical care at UA Homes and at Ernest P. Harris, which are two permanent supportive housing sites in Berkeley. And we're seeing as people are aging and they are having cognitive decline, and that it gets to be more difficult for people to stay in housing because of those issues. And there's not great resources out there. So I'm very concerned about what's going to be out there for people who are both on the streets, but also in permanent supportive housing, and people with serious mental illness as they age, and having the right level of support and having a setting where they have people caring for them in the right structure so that they can stay as independent as possible. But the combination of aging and what that they may be experiencing in terms of their physical health as well as their cognitive capacity and their ongoing mental health needs, all of those things interacting, as well as whatever medications they're taking for those conditions, that there are people who understand how to really hold that and provide a good, healthy environment for people to be in.
So we have about 7 more minutes, so we'll go back this way. Cheryl?
I was wondering how you could unite your electronic medical records with Berkeley Mental Health.
Steve, do you want to?
I think someday it might happen. I think there's a plan to roll out Epic, right?
We're adopting a new health record in October called Epic, which will enable us to connect with the hospitals, which is a good first step.
And then I think the county's actually been working a lot on trying to have a intermediary where the FQHCs could, and then especially mental health in the county, where the kind of important information, because it's a much larger issue than Berkeley mental health, can be able to see the relevant parts of each other's records. I also think there's a pretty decent chance that eventually that the county will move to Epic for their health record. They had made another choice, and then I heard they went back and they're re-looking at it. And as folks know, we use the county electronic health, well, we don't have an electronic health record right now, we use their electronic record keeping system. And we would use their electronic health record when they do one. So I think down the line, that is likely to happen, particularly given that Epic is the choice now for the FQHCs, because it's been used in other counties as a behavioral health system as well. So it is possible to do.
And we merged with East Bay Community Recovery Project, which is based in Oakland. We merged with them in July. They became part of Lifelong, so we now have a specialty mental health and substance use provider in our own organization. And as we're adopting Epic, we're creating, together with the other FQHCs that have specialty mental health, the capacity to chart and document specialty mental health services in Epic so that it meets the requirements for specialty mental health Medi-Cal billing and documentation. So, we would love to see either that the county and the city adopt Epic, or that there is a way for the data that we collect and he collects to connect through an intermediary. These types of things tend to be very expensive to do. The only reason we're getting Epic is that it's getting underwritten by some huge grants from Kaiser and Sutter.
And then I was just wondering if you had like a nutritional assistant?
We have a registered dietitian at Lifelong. We also, there's some of the other things that we offer that are, we have substance use counselors, we have registered dietitian, we have podiatry, which is particularly a big deal for our homeless clients. We have at both our Ashby and our West Berkeley clinics, we have kitchens that we use where we can do cooking classes, and we do exercise classes, and we also bring to all of our clinics once a week. Our AmeriCorps, we have a relationship with the farmers markets, so we do vegetable and fruit giveaways once a week where people can come and get healthy food at the clinic for free.
What day is that?
It varies from one clinic to another, so you have to find out from each individual clinic.
They did one today.
At
At
which
West
one?
Berkeley.
At West Berkeley. Yeah, whenever I go on the day, I'm like, this stuff is beautiful. It's really nice.
They're looking for donors.
So, like your Berkeley clinic, can only Berkeley residents go to the Berkeley clinic?
No, we have people coming from
Everywhere.
Oakland. Yeah, it doesn't matter. Like if you're on Medi-Cal, you typically have people who are on Medi-Cal are members of a managed care plan that's based in Alameda County, and you have to stay within whatever the network is that they have. But we have people from all over, and people move around also depending on.
Just real quickly, you were talking about the alternatives to the opiates. Could you spell out that second one?
The buprenorphine.
Yeah.
It's B-U-P. Then you're really going to test
What is
me.
that?
B-U-P-R-E-N-O-R-P-H-I-N-E.
Yeah.
Like I'm in a spelling bee.
It is.
Buprenorphine. B-U-P-R-E-N-O-R.
And also the gosh, short-term memory loss. I'm sorry, but
That's okay.
the third one, the methadone.
Methadone.
Isn't methadone a treatment for heroin?
It is.
So
It's used
in a
as
sense,
replacement.
you're taking people off opiates,
Uh-huh.
but you're putting them into a heroin addiction
No.
by using the methadone.
No, methadone, you don't.
Does it have the same effects of taking heroin?
No, it does not have the same effects, and it is addictive. It is, yeah.
It's
it can,
addictive, right?
you have to taper off of it if you want to get off of
So-
it. It's a lot easier to get off of than heroin, and there's a whole. I mean, that could be a whole probably 2-hour or 2-week discussion around the benefits.
But I just wanted to bring that up, to make that point.
We only prescribe, so just to be clear, because I want to make sure you have correct information, methadone can be used as a treatment for heroin. It has to be managed through an agency that is licensed specifically to provide methadone, and those are methadone clinics. We are not a methadone clinic. The only time we use methadone is that methadone can also be used to treat pain, and it's used in a very different way than when it's used to treat heroin. So our providers can prescribe methadone specifically for pain management in very small doses. Buprenorphine, at least the current research suggests that buprenorphine is a healthier alternative to methadone if you are going to use medication to get off of heroin or off of other opiates if you want to stop using them and you have an addiction.
Well, because lifelong is so big, I know that you have a lot of metrics in order to measure not only the delivery of services but the cost. And I'm really focused on systems integration. So when I look at Berkeley Mental Health, for instance, I have a couple of examples. In the annual update last year, I believe they asked for money for a substance use expert. Now, if you're doing an MOU, that's the first thing that I think is a need for not only the substance use disorder, but the harm reduction approach and strategies. And I would like to hear more on meth, because there's sort of a large group of people, very large, at Berkeley Mental Health that are struggling with meth. The other part,
Can I just interject there? Is that one of the things we may want to talk about? I don't know, Steve, if you've had conversations with Ashby specifically about getting a new provider into the clinic, embedded into the mental health clinic. But one of the things we may want to consider is whether we can get a provider who is ex-waivered and can provide buprenorphine and how that would fit. We can explore that.
Yeah, this, our medical director, Dr. Jones, is actually exploring this. We have a very small number of folks. We're exploring it, but we're not sure if it's really worth the effort of licensing the site and getting the place for that, because he estimates that we probably have maybe 5 folks.
We didn't have to license ourselves.
No, right, to get.
We don't keep it on. We don't keep it on.
Yes, no, you don't. It goes to the psychiatrist. We've been exploring a couple grants. It's such a small number. I think the issue that Margaret raised was actually more accurate, which is meth. It was.
Meth. I thought you said meth. I'm sorry.
Meth is by far the bigger issue for the folks that we're working with.
We have the same. We've seen a huge, and going back to your question, we've seen an enormous spike in meth use in around housing. It has created havoc in terms of people's ability to hold on to housing.
Well, what can we do about harm reduction?
We should all sit together and talk about where we're finding any positive impact.
We've gone to the county, we've gone to the state. So far, there seems to be almost nothing that seems to be being effective, because the drug is such a quick reward drug.
Focus.
So the last thing is, you have Alameda County Connect, City of Berkeley is a partner, your whole person care.
Yes.
But when it comes to their clients, Ashby is not always that accessible, and like the wellness center is going to go into place on University. It seems that Lifelong could do something with Bonita House, who's going to run that operation. So, you have the community meal at the Lutheran Church, you have Berkeley Mental Health down the street, you have Wellness Center almost next to Trader Joe's. Potentially, that might be a good way to integrate primary and mental health care as an option. And I guess because I don't see something formal in place, people who have serious mental illness and substance use disorder have a lot of things going on, like you said, the heart arrhythmia potentially, but also diabetes and all these other things that are invisible that a mental health clinician's not going to pick up on. So it seems if the locality is accessible, people might be more willing to go there, and also perhaps a foot clinic. I mean, there's a lot of options that I think could be done with Lifelong and Bonita House.
So we've actually been just starting some conversations about how we might be able to start a small primary care effort that would alternative setting outside of our 3 Berkeley clinics. And that would be focused on serving homeless and people with serious mental illness. And we'll be getting into actually the weeds on whether we can make that happen in a formal way with the city of Berkeley. We've had several conversations actually, with Jesse and with Steve and Paul, and so we're very interested in doing something like that. We have a clinic in Oakland called the Trust Health Center that was funded by the county through their Healthcare for the Homeless program and MHSA dollars, that we combine funding from the county with our ability to bill, and we're serving exclusively homeless and folks with serious mental illness and substance use disorders at that clinic. It has a completely different feel to it in terms of how the clinic runs. Mostly it's drop-in. It's got a very large percentage of providers are behavioral health providers, as well as the medical side. There's clothing, there's computers, there's showers, so we're looking at what's the potential to do something similar with the city of Berkeley, and also potentially run a street medicine program out of that. So that's something I've been wanting to do for a very long time in Berkeley, and we're trying to figure out how we can fund it and where it could viably sit. And that would be I think that would be really a fantastic thing to happen. There's a lot of details that need to be worked out, obviously, to figure out how to fund it and how to make it happen, and where it makes sense to collaborate with existing county services like the homeless outreach team or other, work that's being done out of BMH, and then where, what pieces we would do. But I think there is potential, and we'd be very excited to see that move forward. We've launched some street medicine in Oakland too. We're testing that in Oakland. I have no cards with me. I'm very sorry, but I am happy to give you my contact information.
Emails everybody.
Buna, you can feel free to email send everybody my contact information, phone and email. I'm happy to have further conversations. It's there's a lot to be done.
I'm a member of Lifelong, that's why I wanted to contact you.
Yeah, sure.
I was so impressed by the over 60 clinic. That's where I go next.
And we're doing a really cool project out of there right now for people who are very.
One more question.
I was just curious if Alameda County could fund the Trust Health Center in Berkeley.
Well, have some conversations with your Alameda County. We have not found that they have put a lot of resources towards Berkeley in terms of for mental health, because you guys have your own mental health department. Things tend to stay segregated. We're all for whatever money can come in to fund things here. So, I'm sure.
So folks should look we're planning in our MHSA plan to include money for a planning grant for this type of health clinic in Berkeley. So I think that this year's MHSA plan, we're going to put some money so that we can potentially hire a consultant and look at how we could help support such a project. I think everyone would like to make it happen. I think as Brenda said, it's a question of the number of folks is so much smaller in Berkeley that trying to have a robust enough place where you can provide services for folks, but also have enough traffic into it that that the cost of the subsidy for the billed services isn't overwhelming is the issue we need to figure out, as well as the location.
Thank you so much.
You're welcome. Happy to come anytime. I love talking about this stuff.
Yeah. Please give my love to Marty.
I will. Thank you. Out of town right now, but when he comes back.
So, is it okay, because Buna can't actually email everybody, but
No, I
Brenda
think
can.
Karen.
Is it okay?
Sure.
That to send out your contact information?
Yeah, absolutely.
It's okay. We're just going to get you the information. That it comes from Karen or from Andrew.
That's the issue I have, because the accessibility that we have. I don't want everything just to be with Buna.
No, nothing is with me. Nothing is with me. Steve is reminding me.
That's all I'm saying. I mean, I want to have accessibility.
Surely, nothing
Send
is
it
with
to
me.
everybody.
It's all, I have to send whatever I have to Karen. Karen has to send it to you guys.
Okay.
I don't hold anything.
All right.
Yeah, don't worry about it. mental health manager's report. Steve, I saw that it was, pretty direct, straightforward report.
Yes, I wanted to also hand out, because you guys requested it, and I saw it on my to-do list. You guys had asked for the duty statement of the family services specialist, so here it is. So I printed it out. It was just a request from last month. You guys wanted to know those details. The report's pretty straightforward. I'm happy to, I think the highlight for us is that 2640 had its groundbreaking. It was very exciting. The architectural firm came by 1521 today, and at our managers meeting, showed us various finishes, floorings, paint colors. Very exciting in terms of that piece. That is our big news in terms of that, and I'm happy to answer whatever questions folks have on the report, the topics in it, or anything else that folks would like to talk about.
If that's all possible, if we could hold our questions until towards the end of the meeting, so I can get through a bunch of action items that have lined up on the agenda, so they don't end up, they're time sensitive, so they don't end up in the next month. So moving right along. Subcommittee reports, site visit has a report and some things to pass out for you guys. We met, Shirley, we missed you, but we were sick, and have put together a process and guidelines for facilitators, like a cheat sheet for the people who will be facilitating our first group, focus group with consumers. So when you read this, don't look at it as this is more guidance to those of us who will be in the room doing the process piece. And I would like for everyone to get a copy. And if you have any comments, please call me, or email me through Karen. And Shirley, I really wanted to look at this. And I added, even though this won't be until June, I kept you on this day and hoping that you can come and support and help. And Paul, I added you.
Oh, thank you so very
Because,
much.
so here's,
And
I really need feedback on this.
okay, thanks.
At this point, it's just, the way I do things. So I'm happy to. We're hoping the third week of June, and very excited to do the outreach to all the places where Berkeley mental health folks get served, including Lifelong. Seems to be probably maybe one of the biggest ones. But we don't need any action on that tonight.
And I apologize, but just to remind folks, to have the back and forth, it should go through Andrea, because Karen's on vacation, and then Devuna, and then back to Interlevy. So that's to keep there from being a sequential meeting.
This was emailed to everybody.
Yes, no, I know. It just in the request for feedback, it needs to go through the secretary and then out to the.
Yeah, that's why I get what you guys do. The diversity subcommittee.
We met, and we focused on the making sure that the topics of the diversity committee were in the annual report, which we're going to discuss later. And that was basically the focus of the meeting.
The accountability subcommittee.
Can I add one thing to the?
Sure.
I just want to say, the priorities for next year for goal 2 on diversity were discussed by the committee as well.
Everybody doesn't have a copy of the annual report.
Oh.
Lucy gave me one.
What we do need is a vote to extend the accountability subcommittee because we have run out of ideas. So we need a motion.
I'll make a motion to extend the accountability subcommittee
For another year.
particularly to ensure implementation of any of the priorities contained in the annual report 2018.
And again, I apologize. Do you need it today? Because you didn't say in the minutes that you were going to have a motion about this. And so unless you have to do it today.
We have to.
This is,
And Karen,
look,
ask
Steve,
me.
actually,
Hold on. Unless you have the language.
I do have it, and also
the guidance in the new commissioner's manual is that the way we were doing it previously, which was to say that there may be action on anything, isn't in the spirit of the Brown Act. It's to be very clear on exactly what items you're going to take an act on so that members of the public can
Well,
do that.
last
It's
month,
totally good. I said my bit, and you guys should go forward.
Thank you
and
very
I'm not saying you're doing anything wrong.
Right.
okay, okay.
All right, so what I want to do is make a motion to extend the accountability subcommittee in order to implement the priorities contained in the annual report 2018. And I just want to say at the last meeting that this was discussed and there is no surprise here as to making a motion. So we clarify that we're not trying to do anything that nobody knew anything about. So I would like to ask for a second.
So Margaret, could you repeat the motion so Andrea can write it down?
Yeah, I want to make a motion to extend the accountability subcommittee specifically to implement the priorities contained in the annual
So,
report.
one more. Extend the accountability subcommittee
And then comma specifically,
specifically. Okay,
to implement
to implement. Okay,
the priorities
okay,
contained in
okay.
the annual report 2000.
Okay. Okay.
I'll second.
Roll call. Okay. Arlinda?
Yes.
Rhoda?
Yes.
Cheryl?
Yes.
Margaret?
Yes.
Shelby? Paul?
Yes.
Ben?
Yes.
And Shirley?
Yes.
Next, membership committee, be ready to go, right?
Yeah, Shelby, Eva, and I met. Shirley was sick, but we took time to look at the statute that provides the different requirements for members that are part of the commission. And then we composed a list. Shelby let me know all of the different organizations that she would want to send the membership information. And so I now have a list of about 25 or 6 different organizations, and any others. I think Buna has some ideas about where she wants the information to go, and our next step at the next meeting is to get the information dispersed so we can get candidates.
Yeah, we'd love to have, no, I'll wait until May's mental health month report to talk about how we can do some dissemination of materials there and the
Oh.
people.
I do want to make a motion. Well, I can wait, I guess. Buna, are you taking care of how we're going to disseminate the information?
I am going to speak to that under, this is how I'm seeing it happening, because, that each one of us will get the packet, and can start passing it around to the people that we meet, that all requests that the mayor and the council also announce in their monthly newsletters that we have openings. It will automatically go to the big list of stakeholders, out of parents,
That's the Mental Health Services Act.
mental health stakeholders, and also to other CBOs and all the commissions. Because there might be commissioners serving on commissions that might also be interested in serving on this commission. So that's sort of the, and UC Berkeley and, Berkeley City College. So that kind of wide outreach.
Okay,
Go ahead.
I just want to have clarification. Can you put an intro email paragraph together so we're all using the same messaging if we're sending out email to reach out to people with the flyer and the application for
I have to check with Karen to
Okay.
see if we can do that as individual commission
That's
members.
what I wanna know.
You can do it as individual people.
People.
You
Yeah.
can't do it as representing the mental health commission, but
That's
it's
why.
make
kind of the
sure
same way just from you as a person. And you want to get some standard language for that,
That's
which
what I
makes a
want,
lot
I
of
want
sense, Margaret.
standard language that everybody.
That you can cut.
That way no one gets in trouble.
Exactly, I
That makes
just
a lot
wanna
of
make
sense,
sure
Margaret.
these are
Okay,
separate.
so as soon as Karen comes back, the two of us can work on it.
Okay, great.
So when does it go live? That's all I need to know.
It's done, we made a motion to approve it
Okay, then it's done.
at the last.
So now we just
meeting.
start disseminating.
Yep,
Okay, thank you so much.
okay.
Discussion and possible action on draft mental health commission annual report. Ta-da. Absolutely.
So in the minutes, which I wasn't here for, I shouldn't pass them, but I'd like to just amend it because it says that I was absent for the last meeting, which I was, but I wanted to state because I had a work session.
This way.
Right.
Well,
I
I don't
would
think that
just
we
like
did
to have
pass
that to be recorded in the minutes.
Did we pass the minutes?
Yes, we did.
We didn't.
I don't think we did.
We passed the minutes.
I don't remember us
We
having a
didn't pass
motion.
the minutes, we passed the agenda.
Yeah, I think that's correct.
Oh, let me go
Okay.
back. Thank you so much.
Well, then, can you just note
Yes.
that in the minutes?
Let me go back.
Revise it so that it's in there.
Thank you so much. Okay, approve, I'm gonna go back and then come to number 6. So approval of the February 28, 2019 minutes, which are in your packet.
With the, clarification that Davila had a absence because of the work session.
I would really like to request that when one commissioner is speaking, that we are respectful of that commissioner speaking, so we can all hear what that person is saying. So could you please repeat
Yeah, I would
the
just like to,
direction that you want to make?
I would just like, after the absence, that says absent Davila, city council work session, attended city council work session. Because otherwise I would have been here. I don't want people to think I was absent for any reason.
So I'm passing out the,
Sabrina, we still haven't passed the minutes. Oh, there's not even a motion on the
A
floor
motion
yet.
to pass the minutes,
As amended, correct?
as amended.
I'm sorry, I'll
second it.
come in. Roll call, please.
Andrea, take your time and write down the motion,
The
because you're
motion
not gonna get it
was
later.
to
Adopt meeting.
The minutes,
From
As
the last-
amended.
the last
The amended.
last month's minutes as corrected or amended.
Okay. Thank you.
And yet you write down your person made and the person who seconded, and then do your roll call. But finish, make sure you get all the motion down.
So adopt minutes as amended. Okay, and then the motion was by Cheryl,
No.
Yeah,
okay, and then it was second by,
Me, Margaret.
okay.
And then,
and you got the amendment, right?
do you have that? Andrea, do you have the amendment?
Adopt minutes as amended.
Do you know what the
have the
amendment?
amendment?
You put in parentheses or something.
The
Cheryl was not,
The amendment after the absent Davila
amendment,
I mean, yeah,
is, so just say like, attended
Had to
city
attend.
council work session.
okay.
city council work session.
Right, and then just one more thing, Andrea, when you said pass the minutes, it should be pass the minutes of
Okay,
February 28th. So that it's clear what minutes that you guys passed.
pass the minutes of February.
28th as amended, and then you have the amendment in parentheses, so you have it.
Okay, and then attended city council,
Work session.
okay. Okay, and so Erlinda,
Yes.
Luna, I'm here. Cheryl,
I'm gonna abstain since I wasn't there.
okay. Margaret,
Yes.
Paul?
No, Paul, you weren't.
I wasn't
He was
either. Thank you.
And Ben?
Yeah.
And Shirley?
Yes.
So I'm gonna, we good? Ready to move on?
Yes.
I hope I made enough copies. 1, 2, 3, 4, 5, 6. Margaret and I probably don't make copies.
I will
Is
get
that
back to
okay?
you if I do.
Oh, I already gave you. And I gave you a copy, Margaret?
Yeah, I have a
Oh, you have a copy. Yes. So, I think you all will be very impressed with the work that has been done on this report. And I want to thank Margaret for doing a tremendous amount of research and writing this year. And has worked extremely well, as a team member. And,
Sorry.
and what I would like is for you to take, for commissioners to take 10 days to send us comments. Let me know tonight if you need an electronic copy, or if you want me to come around and meet with you and get your comments in person, or in any other way you would like. A couple of the things that we're going to add to this document are quotes, some personal stories, and I believe that there are a couple of pieces that we need to strengthen, especially around goal 1, and I think there was one other goal that we thought we could strengthen. But it's come together very, very nicely. It looks good. It will look even better than it looks now. I have let 2 community members look at it. One has helped editing it, and the other one is helping write the cover letter that will go with this. So we're beginning to get volunteers willing to do work for this commission, which is a really good sign that people are becoming excited about supporting our work. So is there any other way that you would like to give feedback back to us? So Paul, you would like an electronic copy?
Yes.
Cheryl, Linda, you're good? Shirley,
What was that?
would you like an electronic copy, or does this work for you that you can do your comments on this? And then,
This will work.
okay, then just give either Margaret or me. Call either one of us and we'll come get it. Margaret?
Yeah, I just want to point out to everyone that you look at goal 5, oh, it's not here. Oh, maybe the answer. Okay, so you look at goal 5, and it's the one that is the first statutory requirement, that is where we are asked to review and evaluate needs, services, facilities, and special properties. So one of the things that we've done that's kind of analytical is not just list, but actually look at the role of different kinds of things that are important and relevant to mental health right now, like integrating primary and specialist care, the access to and the role of technology, universal health care, evaluating Berkeley mental health sites. Those kinds of themes are going to be integrated throughout this so that the content becomes richer and just listing lists throughout it. I mean, we really have a good outline with the goal, the accomplishments, and the priorities, but we've got to run the themes through it and tie it in with the quotes and the stories and stuff, so that if somebody picks it up, they're not just like looking at lists, but it's actually content rich too.
We would like to have the final come to the April meeting for approval so we can send it to the council.
So, there's nothing under goal 8, under accomplishment.
Because when we went through the minutes, there were no accomplishments under that goal.
Okay.
But when we're going through it again, there are things that kind of stand out that didn't get in the minutes, but that were in the conversations in the subcommittee or somewhere else. So we still have one more cut to do on this to make it a little more human, Right now, it seems to be very dry. So if we wanted to let you see where we're headed. So this is the meat of the report. And now the design and the sense of warm and fuzzies will come later.
Yeah, I also wanted to let Cheryl know that some of the evidence-based practices are under the goals. Like Goal 2 has the national class standards, which are the standards for minority health on cultural competency from the federal government. Those have been in place for quite a while. They're not something new. So what we're going to have to do is link what's with other goals into Goal 8. Because that's just something that has not been done yet.
Okay.
Yeah, but it will be there. And the other thing that I'm doing is going through all the emails sent to commissioners with articles and all those other things that had studies in them. Like, also under diversity was a California healthcare disparities report that went everywhere. So some of those things will get drilled down and put into Goal 8.
Either into Goal 8 or as bibliography.
Yeah.
That word.
Yeah.
Because I'm sort of pretending that I am the mayor of Berkeley and I get this report and I read the first page and I want to read the rest, but I don't want so much that after page 3, I just kind of turn it over to someone else and say, here, it's that person, you read it.
It's also gonna have an executive summary that's like 1 page that pulls it together. Like, you know how we did for the restraint device?
Yeah.
Well, there's gonna be like 1 page that just like very succinctly,
And a letter from the chair. So there's 4 of us working on this and designing this thing, and Linda has given us feedback twice during this process.
and we need your
So we
feedback too.
get Linda looped into this. Staff has absolutely nothing to do with this, so I'm not even showing them the draft. They'll just see it when it goes to them. Yes.
This is the first time I've seen this, and I just want to say, in all of my time on the commission, we've waited and worked trying to get to an annual report. And for all of you who worked on this is a magnificent piece of work compared to where we've been. So thank you so much.
Margaret,
Yeah, I know.
Linda, myself,
Everyone,
and two
we
of
took
them.
everybody's work and put it all together.
Actually, the entire commission, the work that we got done in
Yeah.
2018, and sort of the shift that we made from not being able to get things done to now getting things done as quickly as possible, and that's taken some time. But I think now, the way it's written, the priorities under each goal are listed. So we just keep going. We get priority after priority after priority instead of kind of floundering around.
And I realize that in terms of history, nonetheless, aside from the history, this is a giant leap forward. So thank you, thank all of you.
Thank you.
Yeah, everybody contributed.
2018, we should
Really.
have a cake.
Well, I just wanted to mention too on that, everybody did something at each meeting.
Everybody did
And we went
something.
through all of the minutes that were adopted and pulled out everything from them and then analytically dropped them where they were supposed to be, and this according to the goals. So it's really bringing together everything that people have done, from reviewing documents to integrating minutes to looking at notes from
It's going to 30 pages, coming back to 14, now we're
Yeah.
probably set somewhere around 17 or 18. It'll look very beautiful. I'm hoping that we can do it in color, at least the electronic copy in color. So, thank you, Paul. Motion to approve. May is Mental Health Month, council item. The council item is in our packet. All we need to do is take a vote. This is the resolution that goes to council.
I'll make a motion to approve
I'll second.
Motion to approve.
May's Mental Health Month.
Okay. motion by Sharon, and then second by me. Orlinda. Okay, so Orlinda? Yes. Mona?
Yes.
Cheryl?
Yes.
Margaret?
Yes.
Paul?
Yes.
Ben?
Yeah.
And Shirley?
Yes.
Thank you very much. Now we're looking for a commissioner to be on the MHSA Advisory Committee. And here is the information of what that role means. So please take the time to read it. And if you're interested in being on that committee, let Karen know. Or let you know.
Yes.
Yes.
And then, make sure Karen's aware.
And the people in the community,
What's the SA stand for?
Mental Health Services Act.
So. I'm always up on my acronyms.
Yeah, when you said FQHC, I was going to.
I know, I
That's
didn't-
really qualified.
I didn't know what that was, and I was happy that, Shirley asked the question about how to spell the drug, because I didn't know that either.
Well, when she said it real quickly too.
Yeah.
And I've never heard that word, the word before.
It's a tough one to say.
So we need a motion.
You'd have to be a doctor, I guess, to.
I'm impressed
We
you
just
need
need
to
to
spell
vote
it.
now, because we made the motion, and it's supposed to second it.
So we need a motion to approve background material in support of the resolution passed on police use of the restraint device.
But don't we need to vote on the mental health one? Or no?
Which,
That was-
all right, May's mental health month. Did you
just
take the
voted.
roll call?
Uh-huh.
You took the
Oh,
roll
we
call.
just,
Okay.
I just did it, I'm sorry.
It's okay.
Spacing out.
So motion to approve background material in support of the resolution passed on police use of the restraint device. That's for number 8. That's for number 8.
Can I clarify what that means? It was in the agenda packet, it's the proposed 2-page, piece. I just wanna say, I took it, I researched the study, dropped all the footnotes in, and as soon as we make the motion and pass it, all of the titles and stuff will be taken off and it'll be formally, approved and finished, so it can be submitted to the city council.
And then I'll write the, and I'm gonna teach Margaret how to also learn how to deal with council items. I think all of us should learn. Because, you know, Belinda, maybe you want to be part of that as a vice chair. If I'm not here, you might have to write some item for city council. So it's a good exercise to learn how to do those.
Okay, and
So we can
I
do
missed
that.
the first part.
Hmm?
What is,
Well, then we have to write the item that goes for
city
consent
council.
to the city council. And there,
The police restraint.
oh, I'm sorry, I missed that first part.
Yes.
You're talking about the paper thing.
Yeah.
Okay.
Number 8, the motion was to approve,
number 8, yeah. Motion is to approve the background materials.
the
I didn't need to say what that is.
Well, I'll keep hoping we'll name those. The document will have a name,
so motion to approve the background materials
in support of the resolution
in support of the resolution.
passed on police use of the restraint device.
Well, it's the 2-pager.
I'm trying to call it. This is fine.
Okay.
You know what it is, Karen knows what it is.
Right, and I clarified it on the
Yeah.
record, so that's not a problem.
Okay, so, motion by.
Julia made the motion.
I didn't, I just read it out to you. I didn't,
Okay, so
As
the,
chair, try
it's
not to
just
make
to
motion.
approve this 2-pager.
Mhm.
I'll make a motion to approve the police use and restraint devices if it's, or not to use, actually.
Okay, and second by,
I'll second.
okay. Erlinda? Buna?
yes.
Cheryl?
Yes.
Margaret?
Yes,
Paul?
Yes.
Ben?
Yeah.
And Shirley?
Yes.
Berkeley Mental Health staff announcements and update.
Okay, so we have Men's Mental Health Month 2019, and we would like for everyone to come and join us Thursday, May the 16th, 2019. And that would be Judge Henry Ramsey Jr., South Berkeley Senior Center. And that's at
What date is it?
Thursday, May the 16th, 2019. And that's at 2939 Ellis Street in Berkeley. And the time will be 5:45 p.m. to 8:30 p.m. And we'll have refreshments served. And then
Is that the South Berkeley
yes,
Center?
yeah. So we have, I have some extra copies of the flyer on the table there so that everyone will be able to pick up one and have a copy of it.
I had a request
Mm-hmm.
if that could be, this was sent to us, but as an attachment.
Sure.
Is it possible to send it to us as part of an email?
Email? Sure.
Yes, so instead of attaching the flyer,
Okay.
those of us who are trying to get people to come,
Okay, so we'll send an email.
that'd be good,
Okay.
with the flyer content.
And then also we have the abridged.
Let me just clarify to make sure that Andrea is completely clear what you're saying. What you're saying is to take the contents of the flyer
Yes.
and copy that and then
Into an
paste them
email.
into actually the body of the email
Yes,
and send that
Yes.
out, not send it with an attachment of the flyer. That's what
I'll,
you're
I'll,
requesting?
we'll talk
Yeah, it's a
later.
body.
We'll talk
I
later.
just want to make sure that
Mhm.
That's
fully
I'll make
following
sure
what
that
you're
that
asking
Because
for.
I would think that we would be able to attach this flyer.
Yeah.
That has
Says the
been
one
attached
attached.
already.
Oh,
They
okay.
can see in the body of the email. So they
Got
can
it.
see it instead of,
Okay.
yeah.
Yeah,
They won't
that's
open
easier
it.
to forward.
Yeah.
And then attachments, a lot of people that
Nobody will read it. They'll
send
read it.
invitation, they're like, oh, another thing to do.
And then we also have the abridged Commissioner's Manual for 2018.
Oh, thank you
And
so
then
much.
we'll pass this out to everyone. So there's one.
And Linda, did you, watch the tape or go in?
Did I do the training?
Yes.
Yes.
Okay, I did too.
Can I send my phone in?
We're done with that.
Oh, thank you.
So 11, was that it?
That's it?
Discuss public right to information about individual commissioners and possible action in responding to communications from members of the public and our role as individual commissioners.
Well, we can't do that one.
No,
We can't do it. We have to provide our email to people. That's my understanding, is that if a community person asks for the email of a commissioner, that, no?
I would say, this is nothing
I
an
think we
expert
need
on.
to ask the city clerk.
I would completely agree with that, because this is nothing like,
Yeah.
I would think the answer to that is no, that the communication would go to
Okay.
to
Right.
the secretary and then get sent out, but I am not an expert on that, and
That's
I
what
wanna
I
maybe
thought
format the
Karen.
question, send it to Karen, and we can send it to the city clerk and get
Yeah,
a
I asked
response.
Karen because
And,
she asked if she could give out our, and I said, oh, it's public knowledge.
no.
No, I don't believe it
It's
is.
the content of the
Okay, got it, it's going to
communication.
city clerk.
Mine is public.
Yeah.
I
Mine is.
I'm doing it.
Yes, ma'am.
I did wanna say, if I received something, I would forward it to Karen and copy to Boona, because I don't wanna respond to the public that's not in concert with
That's
the
right.
commission.
And even beyond that, the commission is only supposed to communicate
Right.
with city council and with
Well, I feel the commission has to vote by motion in order to take action, and for me, unless I'm doing this in an individual capacity and not representing the city, which is the exact language of the manual, I don't think I have any business. I just think he's safe. At the end of the day, that's how I feel about it.
Margaret, I think that is the values course of action.
Okay.
But let's ask the city clerk and get it from the city clerk, because they're the expert.
And I still think as a commission that we can have a protocol about how to manage something for the outside member by sending it to her and doing it. Somebody can say a lot of different things about email.
So we agreed that
It's going,
city clerk.
Yeah.
And next of them.
Go when.
so prioritize agenda items for April meeting. I have a suggestion to see if we can, and Linda, that would probably be you and me who would do that when we do the agenda, is to put the action items up front. Then the preliminary items, then whatever else we do, then things that we need action on, then Steve's report, and then
I have two thoughts. One is, I thought it was really beneficial today to have the speaker come and maybe we need to designate like 20 minutes at the beginning for the presentation and questions, or some kind of idea given to the presenter and how long we're gonna.
I had told her that because I thought there would be a lot of questions, that be about around 30 to 35 minutes, and I gave her exactly 35.
That's perfect.
So,
Una,
yes.
can I ask, you may not want to do it, but just in terms of timing, the Wellness Center construction is starting. They're starting to do their formal planning, and in terms of the programming for next year, if you wanted to, it would be a good time to invite Anita House to have a dialogue about the Wellness Center since it's finally moving forward. This would be a great time if you want to get input to her.
I will ask Karen to send that invitation out.
May I be recognized?
1 second.
Okay.
Well, we've been trying to have a CBO come in and then a city staff person come in. Who would you like to hear from the city?
I want the multicultural and diversity coordinator who did the goals, the trainings. It's on 2 pages in the Mental Health Services Act annual update and the plan. I think it's Barbara White.
Yeah, that's in there.
I want her to come and tell us about what they do.
I think that'd be great.
We have not done goals,
Is it diversity?
or anything.
Is there title diversity coordinator or?
Well, her classification is HSPS, but I believe her title, actually, I do not know, it's something like diversity coordinator, diversity and training coordinator is what I believe her job title is, not her classification.
So,
but I know what you're talking about.
But what I was referring to also is the non-FSP money, that's $318,000 and 767. Yeah, 318,767.
so are you saying that there's a particular thing you want Barbara to
No, I want to
address?
hear her tell us what she does, and then we get to ask questions.
Of course, it's the same way that we do with anything. Okay, so Steve, I will send you an email.
I'm on vacation for the next 2 weeks, but I will forward it to Yvette, who's in my place, because we have an assistant director, and she
Did you
will
say you were
talk.
going? You were going?
Yes, I'm headed to Vietnam.
Pardon?
Yes, I'm going to Vietnam on Sunday.
I got
Wow.
the third person going to Vietnam.
Everybody's going to Vietnam.
Very excited.
Next month will be my last month officially as commissioner. I'd like to do an exit statement.
Oh, that's wonderful.
It won't be long.
Okay.
There won't be a
Let's
narrative.
make sure that's on the agenda.
Okay.
No, none of that, but I do want to
Some of that would be.
do a short statement.
We're gonna put that on the agenda.
Okay.
So,
That's what I thought you were doing the agenda, right?
but we're working on side by side.
So would like the diversity multicultural training officer to explain what she does.
Yeah.
Which is Barbara White. You would like to add that to the agenda.
Yes.
Okay.
So the first thing needs to happen is you or Karen need to send her an invitation.
Okay.
But
Yeah, actually, just send it,
available.
send it to me and Yvette, Andrea. And then
Okay.
Yvette is a supervisor. We'll-
And then for
Okay.
May, we would have Bonita House come and present on the Wellness Center. Folks, we're almost done. We're almost done. Almost. Any announcements from the commissioners? Ask for a motion to adjourn. 8:27. So
Hey.
Right.
roll call. We need a second.
I'll
So
second.
Motion to adjourn.
To adjourn. I'm ready to adjourn.
I'll second.
Second.
We can get this to an hour these days.
Hey, it's getting better and better.
Thank you, my friend.
Okay, so the motion to adjourn is Erlinda? Yes. Buna?
Yes.
Cheryl, yes, Ariel, Margaret?
Yes.
Paul?
Yes.
Ben?
Yeah.
And Shirley?
Yes.